Hello, my name is Domenica Pinto, and this is my presentation for medical English. I will talk about a case report about a 2-month-old girl with growing retardation and pulmonary failure. First, we're going to start by saying that this girl was born with an intrauterine growth retardation. She had a weight that was less than the 25% of the weight of a normal newborn. She also presented hypotonia and hypoglycemia, thrombocytopenia, and jaundice, which were cured at the moment. She was taken into UCI, and she was made some diagnostic tests, and they found out that she had like a borderline cardiomegaly and abnormality in the structure of her lungs, which could only be explained with the symptoms of the Wilson-Michelty syndrome, because this was not a case of a premature newborn. Here we have a video about intrauterine growth retardation.
Pediatrics. The normal birth weight is 2.5 to 4 kg. Low birth weight is less than 2.5 kg. Very low birth weight is less than 1.5 kg, and extremely low birth weight is less than 1 kg. Pediatrics is a dynamic population, so there are no definite values. We talk in the form of percentiles. For example, normal BP falls under 5 to 95 percentile. Term gestation is greater than 37 weeks. Preterm is less than 37 weeks. 34 to 37 weeks is called near term or borderline term. Small for gestational age is less than 10th percentile. Large for gestational age is greater than 90th percentile. Adequate for gestational age falls between 10th to 90th percentile. Now we discuss about IUGR. IUGR stands for intrauterine growth retardation. IUGR is mostly short for gestational age, but some IUGR can also be adequate for gestational age. The hallmark of IUGR is wasting, that is atrophy. Causes of IUGR. The mnemonic is retardation, renal failure in mother, elevated BP, that is PIH, torch infections, alcohol, that is fetal alcohol syndrome. What is fetal alcohol syndrome? The mnemonic is FAS, that is facial hypoplasia, absent philtrum, septal defects such as VSD, and short stature. Next, Russell-Silver syndrome. Drugs. Drugs causing IUGR are beta blockers, tolbutamide, and AC inhibitors. Abruptio placenta, trisomies, infections such as HIV, oligohydramnios. What happens in oligohydramnios? The baby is compressed. There will be Potter sequence, POTTER, pulmonary agencies, oligohydramnios, twisted neck, twisted skin, extremity defects such as CTEV, and renal agenesis. The last one is nicotine smoking. These are all the causes of IUGR. IUGR is divided into symmetrical IUGR and asymmetrical IUGR. Symmetrical starts in the first trimester, whereas asymmetrical starts in the second trimester. The most common cause is gestational hypertension. The most common cause here are the syndromes. The height, weight, and head circumference will be in equal proportions, whereas in asymmetrical, weight is mostly affected and the head is paired. Therefore, in symmetrical IUGR, ponderal index will be greater than 2. In asymmetrical, ponderal index should be less than 2. What is ponderal index? It is weight in grams into 100 divided by height in centimeter whole cube. In IUGR, there is fetal stress. Therefore, levels of cortisol and adrenaline increase. Also, the levels of erythropoietin increase. Therefore, RBC production will be there and RBC level increases, causing polycythemia, hyperviscosity, and there will be increased chance of thrombosis. For example, renal vein thrombosis causes palpable kidney hematuria and thrombocytopenia. Mesenteric artery thrombosis causes NEC, that is necrotizing enterocolitis. PC value will be greater than 65, that is polycythemia, which are associated with birth asphyxia, meconium passage, and meconium aspiration. Due to increased levels of cortisol, there will be early production of surfactant, hence early lung maturation, early PTH axis maturation. Therefore, IUGR will not cause hyaline membrane disease. There will be no hypocalcemia. Fetal wasting. It consists of loss of subcutaneous fat, not bone fat, loss of liver glycogen. Therefore, more prone for hypothermia and hypoglycemia. IUGR is associated with the mnemonic is CHAMP, that is congenital anomalies, hypoglycemia, hypothermia, asphyxia, meconium aspiration syndrome, and polycythemia.
Okay, so now we are going to talk about specifically which were the manifestations or clinical manifestations that the patient had. First of all, the cardiac abnormalities. This patient had a foramen ovale, a perimembranous ventricular septal defect with a small shunt from left to right, with no ventricular dilatation. And she also had a bicuspid aortic valve and a fission of the intercoronary commissures with a small stenosis and aortic dilatation. And she also had a patent ductus arteriosus, um, and this ductus arteriosus showed that there was a ventricular circulation still going on. And now let's talk about the brain abnormalities that were found. We have extensive periventricular gray matter heterotopia that was found on MRI, a large cisterna magna as well, and micrognathia. Now we're going to show a little bit about a case that is not this one, but it shows it shows briefly what gray matter heterotopia is. Let's see.
33-year-old male with a history of recurrent seizures. The coronal T1 and inversion recovery sequences demonstrate an ovoid focus within the periventricular white matter of the left frontal horn, which is hypointense to surrounding white matter but isointense to cortical gray matter. The nodule is also isointense to the cortical gray matter on the subsequent FLAIR and T2 weighted images. The findings are compatible with cortical gray matter heterotopia. Gray matter heterotopia results from the interruption of the normal neuronal migration from periventricular region to the cortex. The end result is normal neural tissue in an abnormal location. Gray matter heterotopias can be subdivided into nodular heterotopias and diffuse heterotopias. The nodular heterotopias consist of subependymal heterotopia, which is demonstrated in this case, and is the most common subtype. Other forms include subcortical heterotopias. Diffuse heterotopias consist of band heterotopia, lissencephaly, and laminar heterotopia.
Now, the pulmonary abnormalities. This patient had abnormalities that were characteristics of Wilson-Mckitty syndrome, and this included distortion of the lung parenchyma or structure, with bilateral fine crackles, with mild subcostal and suprasternal retractions, the development of emphysema, and she had all the time she had a low oxygen saturation in arterial blood. Now we're gonna show a bit about the Wilson syndrome.
Wilson's disease has pleiotropic effects on the body, so it can affect the liver, it can affect the brain, it can affect red blood cells, it can affect kidneys. When it affects the brain, it can affect motor function, causing tremor, difficulty swallowing, difficulty speaking. It can cause problems with abnormal muscle tone, abnormal muscle movements. It can cause psychiatric problems consisting of mood disorders, depression, mania, um, and hallucinations, paranoia. It can cause liver problems, which can lead to jaundiced or yellow color, fluid collection in the belly or ascites, or swelling of the ankles.
Okay, now we're gonna talk about how the diagnosis was made. So, um, doctors were not sure about what was really going on because they had never seen a case like this. They they put this girl into some studies, in imaging studies like MRI or magnetic resonance, CT or computerized tomography, and others like echocardiography. There was several scientific discussion and possible theories that were going on, and they were different from doctor to doctor, from scientist to scientist, and they had to look forward into the genetic and family history, genetical studies, and apart from the ones that were already made. These are some of the imaging studies. We can see an MRI at the right in panel A and B, and at the left there is echocardiography and an angiography at panel B. And here we have some of the family background of this little girl. Her mother had smoked during pregnancy, and she had also taken lamotrigine for seizure problems or the seizure disorder that she suffered, which she was diagnosed with when she was a teenager, and she also had hyperflexible joints. She and the patient's maternal grandmother had periventricular heterotopia as well, so this might explain uh, the, the existence of this in the baby. And the maternal half-aunt also had a seizure disorder, so this is genetical. And the patient's father had a history of depression. And finally, as a conclusion, all the scientifics kind of agreed into one final theory, that was this kid had features that were characteristic of the Ehlers-Danlos syndrome, which was associated with ventricular heterotopia and cardiac defects, and an inherited X-linked dominant pattern with an FLNA, which is a gene mutation, and a possibly alveolar dysplasia, though is genetical. And it was also found that she had a pulmonary capillary hemangiomatosis. This is like the anatomical diagnosis, and it was X-linked. And she also had periventricular heterotopia associated with a mutation of the gene FLNA. And finally, we have a video explaining what is pulmonary capillary hemangiomatosis.
Yeah, the research that we've done is in the field of pulmonary hypertension, which has to do with the blood vessels in the lung. Our research really began back in 1994 when we first started collecting DNA from patients with this rare condition called primary pulmonary hypertension. Recently, we took DNA that we collected in the year 2004, added to it new samples, and discovered a gene mutations that cause a very rare form of pulmonary hypertension called pulmonary capillary hemangiomatosis, which is a medical mouthful, but it's a rare disorder, and it's a form that we've never really understood the cause of and had a very difficult time diagnosing. So I think for patients and families, it actually helps just to say, we've found the cause, we know how it's inherited, we can even begin to predict who would be at increased risk to develop the disease with genetic tests. For some patients, that might mean avoiding a lung biopsy, a surgical procedure that's fairly invasive and carries some risk. So we've specifically been interested in the genetics of this disorder, the inheritance, the genes and gene mutations that might cause it. And in doing that, of course, we hope to have a basic understanding of the disease so that we can find therapies that treat the most basic cause of the disorder, ultimately to reverse and cure the disorder. That would be the goal. The Intermountain Research and Medical Foundation is critically important to the research that we've been able to do, and many others. It allows investigators who understand disease, understand gaps in our knowledge, begin to ask the right questions, collect the right data, and/or the resources. So we couldn't have done it without that philanthropy of the donors.
That was it. Thank you for your attention.